Okay, without wasting much time, we are going over to the next panels. I'm calling on Dr. Daniel Iya, Honorable Commissioner of Health, Nasarawa State. Please, can you come up? Dr. Daniel Iya. I'm also calling on Dr. Gafar Alawode, Health, Finance, and Governance, and Dr. Sani Aliyu, DG NACA. Please, we just have 3 panelists, and it's going to be one of the brief, or it's going to be a brief one. Welcome, sirs. Then the question is about the funding question in universal health coverage. That is what we are going, the panelists are going to talk about. And Nigeria is a complex country with unique development challenges and opportunities. To achieve universal health coverage, large investments is required to really achieve the universal health coverage schemes for all Nigerians. Putting this into account, achieving universal health coverage will be an immense undertaking. The session will tackle the big issue of securing funding, the process of distribution, and the inevitable challenges that come with financing something of this scale. So we'll start by our panelists introducing themselves, and then telling us what they feel about this question.
Thank you very much. I'll start with a little story. I came on board as Commissioner for Health towards the end of 2015. And at that time, the budget had been prepared for the following year, of course, which was 2016. And at that time, the budget was going to go to the House of Assembly, for deliberation, and also going through the usual process. The day before, I saw my governor, and I said to His Excellency, I wonder what you're going to say about health that is going to be in the budget. And he said to me, he looked at me and smiled and said, what are you up to? And I said to him, well, I know that many governors talk about giving free care. And when such policies, when governors make statements, they become policies. So I want to know whether you're going to say, when you're making the presentation to the House, that you're going to give free health care. And he said to me, well, I was planning on doing so. And I said, well, may I plead that you don't mention that you're going to give anything free. Just say that you will be looking at several other options in terms of financing health, rather than stating that you're going to give free medical care. And he did accept, graciously accepted not to say that he was going to give free care, but rather that the state was going to look at other options of providing health care, particularly to the vulnerable groups, the women and children, and we'll look at health insurance as a possibility. Now, for me, that was something that was great, because even before we went into speaking the details, he accepted that there was need to provide health care in a sustainable way. And from there, we've gone on, to looking at health insurance as an option for providing sustainable, qualitative health care. No matter what we say, no matter what ideas that we come up with, if there is no funding, which is critical, then really universal health coverage will be a mirage.
Okay, thank you, Doctor. We'll still come back to you. Now, Dr. Gafar Alawode, Health and Finance Governance, please. Let's hear from you.
Okay, thank you very much, and good afternoon to the audience. I represent USAID-funded Health Finance and Governance project as the Chief of Party. As the name implies, the project is about how do we put necessary policy, institution, and legal framework to reform the health financing landscape. But to this very important question of this panel, the funding question for universal health coverage. Like the Honorable Commissioner mentioned, the issue of financing is very central to whether or not we are going to achieve universal health coverage. And to me, there are 4 fundamental questions which we need to discuss and answer. When we say financing for universal health coverage, the first question is, how much do we need? If you say spend money on this, the political class will want to ask you, how much exactly do you need? The number 2 question is that, who are we spending this money on? Because don't let us forget that we are talking about universal health coverage. Everybody should have access to care without suffering financial hardship. So the question of who are we spending the money on is very critical. Another critical question is, where is this money coming from? Where the money is coming from is very crucial. Money can come from individual. People are spending out of pockets. The evidence has showed that will not lead us to universal health coverage. Money can come from government, we're very critical. Money can come from donor and other sources. But the single and the most important source of funding, if we are going to achieve universal health coverage, is the money that's coming from government. Very, very important. Other can complement it. The number 4 question is the question of efficiency. It's not only about the volume of the money, but how well are we utilizing this money? And the evidence shows that some countries that spend far lower than other countries are achieving better outcomes. It's the issue of efficiency. In order to answer these 4 questions properly, we need to examine what is the policy framework in the country, what is the institutional framework, and what are the legal framework for us to achieve the slogan in health financing is more money for health. At the same time, more health for the money. So this is very important. As a project, part of what we do is that we don't come here and introduce new policy. Nigeria has a set of brilliant policy framework. And what is important is to ensure that this policy framework works. One of those policy frameworks is what has been discussed here: decentralization of health insurance, supporting the state to have health insurance schemes. Part of the reason why we are still crawling with regards to the coverage of health insurance is because we have a centralized scheme in a decentralized setting like Nigeria. So how do we ensure that it works? How do we ensure that the supply side of it in terms of effective management of primary health care system, how do we ensure that it works? Another policy thrust, we have the National Health Act, and the state are putting in place a legal framework for state health insurance scheme. How do we ensure that all this policy framework works? How do we ensure that we have a multi-sectorial approach? I'm very happy we have a panelist of lawmaker that just discussed. There's something that was launched last month by the Senate President himself, Legislative Network for Universal Health Coverage. I'm very happy somebody asked the question of, are the national lawmakers working with the state lawmakers? There is a framework already. There's an institution that brings all of them together. So I think these are part of the things we are supporting to ensure that we're able to reposition the health financing landscape so that we achieve universal health coverage in Nigeria. Thank you.
Thank you very much. And next, Dr. Sani Aliyu, the DG NACA. Let's say you, sir.
So if you don't mind asking the question again, because it's been quite a while, what exactly is the question?
The funding question in universal health coverage.
Okay, so that's a very broad question. First of all, declarations, I'm not a financial analyst, but if you look at the concept of universal healthcare, what exactly are we trying to achieve? What we're trying to achieve is to provide quality care and at the same time reduce the financial risk, particularly for poor and vulnerable people, reducing the risk of being out of pocket. How do you achieve that? You achieve that by looking at certain steps. In the first place, the first thing I would say is, how are you going to get those resources? How are you going to find those resources? And are those resources going to be sufficient? Are they going to be sustainable? And if you look at the Nigeria system, the problem with the Nigeria system, the NHIS system, and apologies to the acting Chief, if he's around, is that the program, the way it was designed, it wasn't really designed in a very progressive way. What do I mean by progressive way in terms of universalism? It's approaching healthcare from the perspective of the poor and vulnerable. Approaching it first from the perspective of the person who cannot access care, partly for financial reasons. If you approach it in that way, essentially what you're trying to do is to get as many people onto cover as possible. That's the first approach. And then the second approach is to then look at what are those health interventions that are available that you want to introduce into the system. Are they cost effective? Are they targeting the most high impact diseases? So for instance, infectious diseases, for instance, vaccinations, for example, issues to do with maternal and child mortality. And then thirdly, how do you get that money across? Do you have a system that's efficient? Do you have a system that's reducing inequity across the board? Do you have a system that's accountable and the governance structures are in place? The problem with the Nigerian health system as it stands at the moment is that it's covering a very small population, a part of the population, less than 2%, I believe. We started off with the government sector, we started off with the formal sector because it's the easiest to start with. But in actual fact, what we should have done would have been to get a pool of funds first, identify those that are in need, put them on cover, and then go on to the next stage, which will be to then look at sustainable funding. And universal health coverage is not possible without mandatory contributions. Forget it. If it's going to be voluntary, it's not going to work. Community health insurance schemes generate very small amounts of money and are not sustainable in the long run. You then need to have, you also need to have a system that identifies taxation. That's what other countries do. So for instance, in the UK, we have national insurance contributions. That's principally what they use to run the NHS, together with part taxation at the community level. But I can tell you the NHS budget for the UK is more than 6 times the entire federal health budget for Nigeria. No, the entire federal government budget, not even the health budget. It's 115 billion pounds. The government of Nigeria budget, the last time I checked, I think was about 20 billion pounds or so, the entire federal government of Nigeria budget. But how do they get the money? They get the money from taxation. And there are so many ways to do taxation. You can do taxation through sales tax. Ghana, for instance, increased their VAT by 2.5%. That was how they used, that was what they used to start funding the health insurance scheme. Gabon used a system which they call solidarity taxes, where they tax money that is coming in from people from outside. So people like me who used to live in the UK, for instance, as part of solidarity, if I'm sending money to the family over in Nigeria, I'll have to pay some tax which will go towards taking care of you guys. And you can also have sin taxes, so increase in taxes for items that are considered to be either luxury items or affect health. So for example, smoking, tobacco. China increased their tax by 50% on tobacco, and that generated more than 20 billion pounds, 20 billion US dollars. And it's considered, it's very likely that they will continue to have that money for the next 50 years in terms of resources. So there are so many different ways. Subsidy is another instance. Trying to get removal of subsidies for things that are not entirely necessary. Taxing the aviation industry. But you need a source of fund that's not only mandatory but also stable, that will continue to come through consistently in order for you to plan. Yes, it's important that we have fiscal policies. It's important that we partner with our legislature. But at the end of the day, unless you can have a secure source of money that's coming in regularly, and unless you're able to plan and make sure that your systems are efficient, the financial systems are very secure, the governance around them is pretty strict, and the health systems themselves are qualitative and efficient, so that you have the support of people who are putting money into the scheme, it's not going to work. And to really conclude, what I would say is, yes, Nigeria, we went down the NHIS route, but we went down the easiest route. It's about time we come back and look at those difficult decisions. How can we expand healthcare to cover our population? And there are ways of doing this, and I'm sure we can get there.
Thank you, Dr. Sani. Thank you so much. I think we'll go straight to the guiding questions. And Dr. Gafar, I think I will ask you this question. There are actually two. I want you to tell us what can be done about the recurrent issue of challenges like investor fatigue. Then can corporate social responsibility be a reliable source of funding universal health coverage?
Okay, thank you very much for the questions. Before I go to the questions, let me quickly emphasize this. In terms of the source of funding, you are talking about investor fatigue, whether donor or private investor. I think what is very, very central is ability of the government to mobilize resources. The DG has mentioned a number of tasks. Who collects tax? It's government that collects tax. So ability of government to collect these resources is extremely important. Let me give you a scenario. In terms of benchmark, I said, how much is enough? We're talking about achieving universal health coverage. How much does it cost? Looking at international benchmark. Of course, there's a suggestion that probably you need nothing less than $86 per person per year to achieve universal health coverage as the minimum. But if you look at the income of Nigeria, or probably the GDP of Nigeria, if Nigeria is actually collecting tax, as we are supposed to collect like average of other African countries that are collecting average of 20%. If you collect 20% of the GDP of Nigeria, which is put around at $3,000 per person, I don't know whether it has changed in the last few minutes or not. If you collect 20% of that and allocate 15% of that to health sector, you are going to get more than $86 per person. Of course, somebody considers it theoretical, but that means at least it is possible, fiscally possible, looking at the macro economic context of Nigeria. So what, like the DG said earlier on, is very, very important to pay attention to ability of government to mobilize resources and spend these resources before we start talking about, okay, private investment, donor investment, and all those stuff like that. From what we have, from the literature and what we have seen elsewhere, no country achieves universal health coverage by depending on external financing, donor financing, for instance. Nobody achieved that. But that does not mean it is not important. It is important. But what is important in terms of external financing? How do we use external financing to catalyze domestic financing? I think that is very, very important. If you look at a number of donor projects, after some time, irrespective of sustainability framework they put in place, after the donor funding, after the 5 years or thereabout, what happens? Even with the best of sustainability framework. I know Magashi and others are doing a very good job. But so how best do we use this external financing to ensure that the government put in place necessary framework to be able to collect tax? Lagos State is a very, very good example. We're not talking about Rwanda, we're not talking about Ghana. We're talking about the state within Nigeria that has been able to increase its tax from monthly collection of less than 2 billion to 20 billion naira a month by doing tax administration reform. So what I would like to advocate for is that how do we put necessary institutional, legal, and policy framework for government to be able to collect more tax. But it's not only about collecting tax. It's about how the money is utilized as well. Before the utilization, it has to be allocated. Because in Nigeria, somebody mentioned Bauchi State allocating 16%. But we have states that are allocating 4% as well. Yeah, in Nigeria. We have states that are allocating 4% of their budget, only 4%. But that is not even the worst news. The worst one is that even out of the 4%, they spend more than 90% on paying salaries of health workers. Only 10% for capital projects. Then when I look at that capital project for that particular state, they release only 18% of the capital project on health. So what are we talking about? So it's very important to position institution. Then when it comes to donor fatigue, donor investment, and all those stuff like that, I think donor investment is as effective as the local institution. If the local institution that is engaging the donor is very effective, we are clear about what we want, we are clear about the direction, we ourselves are accountable. Mutual accountability is very, very important. You cannot keep telling donor how much you are spending when nobody is able to assess your funding as well. So we have to look at these issues critically in terms of we ourselves, are we doing enough in terms of ability to spend domestic financing towards achieving universal health coverage? But the good news is that, like I said earlier on, there are a number of our policy framework. National Health Act is there, which among other things is allocating at least 1% of the consolidated revenue of federal to the whatever, let it work. That is why we are working with the lawmakers that we should put it. Somebody says, okay, lawmaker, if you ask them why is the National Health Act is not being implemented, they will say, oh, it's the federal that did not, the executive that did not put it. But the question is that the lawmaker know how to lobby for inclusion of constituency projects and all those stuff like that. So why can't do the same lobbying to ensure the National Health Act is included in the budget? And the same thing applies to the state. There are a lot of interesting things. If you look at the law setting up the state health insurance scheme in various states, it makes provision for at least 1% of consolidated revenue of the state to be dedicated to equity fund. Because the issue is this: when you introduce health insurance, no matter how low the premium is, there are some people that are not able to pay. How do we ensure that those people, they get funding from the government? And that is why the law is introducing it. How do we ensure that this money is actually included in the allocation and it is released? And that's, I'm very happy we have civil society organization here. How do we track all those things? Another policy framework is PAC or one rule. One of the problems we have inefficiency in the management of the PAC is that there are a lot of institutions involved. Typically, you have, I'm rounding up, typically we have State Ministry of Health, you have Local Government Service Commission, you have Ministry of Local Government, you have local government itself involved in administration of primary health care. And that is why the National Primary Care Development Agency is saying, let's have PAC order one rule. This is a very important policy trust. I'm of the opinion that if we implement very well the necessary institutional policy framework, if we mobilize additional resources, and if we bring everybody together, because it requires a multi-sectorial approach, we have to work with the central ministry. Those of us in the health sector, we are very, very good at talking to ourselves, not talking to other people. We should change the paradigm, talk to the Ministry of Finance, economic planning, talk to the House of Assembly, talk to the National Assembly, talk to the civil society, so that all of us at the end of the day will be able to make USC work. Thank you.
Thank you very much, Doctor. I think the next question, I will address it to Dr. Daniel, and it's what is the biggest challenge to funding universal health coverage for Nigerians? Is it implementation or is it citizen education? So what do you think?
Well, as I started with a little illustration, the issue here is really funding. And I think this is critical. Unless that is sorted out, that will continue to be a problem. Health is not something that you need to advertise. Every one of us needs health. I think the issues really is making services affordable, available, accessible, and as mentioned earlier, that one does not become impoverished as a result of illness. Now, it doesn't matter whether you're rich or poor to start with. I think the critical thing regarding universal health coverage is that there's a pool of resource that comes in. You may not need that much from the pool that comes in, but nobody should go without the needed health because he's poor. So we need to pool all the resources that are available. My colleague here just mentioned what is happening in some other countries in terms of how the resources come. I do not think that it's worthy of relying on resources from outside the country for healthcare insurance, for providing universal health coverage. The examples that have been given, for example, of the UK, which I happen to have benefited from, I was contributing when I was in the UK, and it was through my tax. And the more money you earn, the more you pay into that pool. Okay, so the taxation, which is based upon your income, certain percentage goes into that pool. And I think that has to be adopted. But if you look at our situation in Nigeria, how many people are in the formal sector that you can actually say this is what you should pay in terms of taxation? So it is important that a strategy is adopted such that everyone pays. And I think the responsibility of the government, for example, in an insurance scheme, if we're taking that as a way to go, is that the people who are really impoverished, the people who really can afford to pay, must be government's responsibility, because I see health not only as necessary but also as a social need for any community. In which case, for example, when we're talking about the emphasis on children and pregnant mothers, then it becomes necessary that a scheme is put in place such that government provides for that vulnerable group that are not able to make a certain contribution into the pool. So we need to evolve a strategy. What we have presently in the country, Dr. Gafar just mentioned the fact that the policies are there and so on, but we've already talked earlier that it's a federation unit. I mean, we're living in federation, and the states will need to adopt and adapt what has been presented, as far as the nation is concerned. And we know, for example, at present, that despite the efforts of the last 10 years, only 1.7 million people out of 180 in this country are actually, involved in the National Health Insurance Scheme that we've been talking all about. So each state will need to evolve a strategy in terms of providing universal health coverage. For me, this is the critical thing. And how we're going to do that must be left to individual states to come up with that policy. For example, in Nasarawa State, we have decided that by the way, it's the deputy governor who is the chairperson of the scheme in the state, to show you the commitment at the highest level. We have decided that it's going to be mandatory. It's not going to be voluntary. It has to be mandatory. And for those of you who work in Abuja and live in Nasarawa State, if you are going to access, healthcare in Nasarawa State, you must contribute in one form or the other. Okay. So that is going to be the case. So it is important that we come up with that strategy. And secondly, as my colleague did mention, it's not the issue of just pooling, but management of that resource. We have seen what is happening actually with the National Health Insurance Scheme, with due apologies. HMOs, we have decided we're not using HMOs as a state. We have decided we're going to use other methods, and there will be division of, because it's important the way the money is managed. The person who keeps the money is not going to be the person who provides the money to the providers. That is critical. Whatever states decide that will suit them is important. But I want to end here by saying, as I mentioned earlier, that for me, whatever beautiful policies you have on ground, if you do not have funding, and of course the funds must be managed appropriately to be able to sustain what is being used. By the way, health insurance is just one way of financing health. Okay, we've mentioned other ways where the contribution can come through social corporate responsibilities or taxation and what have you. And again, when you talk about that, it's the government's responsibility to pull money from such sources. But for us to be able to move forward, that needs to be done. And finally, may I say that there are 3 states in the country, which includes Nasarawa State, where we are practicing performance-based financing. And to me, what is critical here in terms of how we use money and how we make people accountable in terms of what we pay them, it is important that government doesn't just put money, but everything must be tied to the outcome, to the output. So we have many people who collect fat salaries, and it's not equivalent to what they do and what they deliver. And I think that needs to be sorted out as an institutional thing, at the state level or at the national level, before we can really be effective in the use of the resources that we're going to use for universal health coverage.
Okay, thank you, sir. I'm going to direct the next question to the DG NACA, Dr. Aliyu. And, we keep talking about we pull in money, we have to follow up, how is this money managed? And the next question goes like this: how can we convince investors and funders to fund universal health coverage, putting into account Nigeria's corruption and infrastructural challenges? Because they are actually the... So, sir, what do you think?
Thank you. So I'm afraid I'm one person who really believes that having huge amounts of donor funds coming into a country, especially a country that can look after itself, is actually not the best. And I'll give you an example. I was talking to somebody from one of the states on state health insurance scheme, and I asked him, so why didn't you include HIV as an indicator disease, both for testing and treatment? They had it as for testing. Is it because you have so and so covering your state, which is an external donor? And he said, oh, of course. So, which meant that if they didn't have that partner covering their HIV services in the state, they would have looked for the funds to deliver to their people. So, as far as I'm concerned, there are a lot of things that you can use to restore donor confidence. One of the things you can use is to try and reduce inefficiencies in the system. We know there's a lot of wastage when it comes to buying commodities, for instance, pool procurement, etc. There are ways that you can actually reduce cost by trying to buy in bulk, by bringing in other states and other parts of government as well into it, by actually negotiating properly and making sure that the procurement system is pretty clean along the whole chain. Because what they don't like really is deliberate attempts to interfere with the procurement process. So that's one way of restoring confidence. The second way of restoring confidence is to show them that actually this is what you need. So for example, with HIV, what we've been saying to our donors is, we don't want your money. We don't want the hundreds of millions of US dollars coming into the country for HIV. What we are interested in are the commodity side. Because every state has a primary health care. Every state has doctors. Every state they have community health workers. Every state can actually deliver HIV services, if not for the lack of commodities. So it's those test kits, it's those antiretrovirals, it's those laboratory reagents, it's those equipment that you need for the monitoring that people do not have. But the states are already paying the salaries for those healthcare workers. They are maintaining the infrastructure. Whether you have HIV or you don't have HIV, that infrastructure will continue to be there. So look for the gap. And the gap here really has to do with commodities. And then insist, this is where we need help, if we really need help at all. The US government spent $4.3 billion US dollars on Nigeria since the beginning of the HIV national response. Global Fund, $1.3 billion US dollars. You think they're going to continue spending that sort of money in Nigeria in the future? No. The other thing that you can also raise is the very strong link between improvement in health indices and economic prosperity for countries. We know if you look at a lot of countries, South Africa is an example where they had an 11-year increase in their life expectancy. That generated a huge amount of GDP for the country. For every 10% increase in change in life expectancy, you get a similar percentage increase in GDP. So it's not only in the best interest of our country for us to have those funds in order to run our health systems, it's also for the global economy as well. So, but whatever we do, we need to make sure that we minimize inefficiency. We need to show that we are providing value for money for the funds that we are receiving. We need to make sure that we minimize inequity. So those patients that cannot afford to pay, there should be a system that allows them to access funding. And for those who can pay, then they should be allowed to pay, but you need to make sure that you provide qualitative services for them, because some of the issues with the health insurance scheme in Nigeria actually has to do with the lack of confidence by consumers. They are not convinced that we are providing value for money to them. And that's a pretty easy thing to change. It's all about perception. It's all about trying to deliver good services. But yes, it's a difficult road to go down, but at the end of the day, we as a country need to find solutions to our own problems. We should stop looking outside for solutions because we can look after ourselves. We have the resources. We need the political commitment to do so. Thank you.
Thank you so much, Doctor. Please, a resounding applause for them. We are now going straight to questions. And please, whatever questions that is going to be asked, we just have 5 minutes to wrap up. So I would want the questions to be snappy. And I would want it just from 3 persons. So if you have a question, let me see your hand. I've seen one there. Any other one? Okay. I'm good with the 2. What's it? Okay, sir, sorry, I didn't get to say you. Okay.
All right, thank you very much. I'll be snappy about that. Thank you, panelists, for a job well done. And my question is, in terms of accountability from the supply end, looking at the states, there's hardly any state governor that has not built a massive hospital, a sci-fi hospital, and yet we don't have these services. And we still have medical tourism, not in favor of Nigeria, but from Nigeria to other countries. How do we address this to get funding from this? Thank you.
Thank you very much. I'm up again. I'm going to center my question. First, I wanted to speak to the legislator before they left, and I'd also ask the present panelists. I don't know whether I'll be having a favor.
The one for the present panelists, please.
Okay. Before coming here, I think I reviewed 2 to 3 documents that talked about health issues. And I was able to identify some of the reasons why those documents, they are beautifully prepared and they are structured well for implementation. But the question that came to my mind, why do they fail? And the question is about funding. Funding is the problem. We want to know specifically from the duty bearers, because we are dealing direct with them right here. What is the problem? If it is the funding, is it because there's no mandatory contribution from the citizen, or the budget line is not enough to complement that? Thank you very much.
Okay. Thank you.
Thank you. Dr. Nauzo again. Universal coverage, everybody will be covered. The question is, why aren't everybody paying? And I know there is money in the system. I think when they did the health account, most of the payments are coming from people who ordinarily would say we don't have money. So they're still paying. It's just not officially. They are going to have a list. They are paying. Money is circulating. So we have to devise a way in which we have like a means test in the communities to ascertain who really are poor. So maybe we'll have community groups or community committees that will, because everybody knows everybody, and we should have some indicators. Like if you are so poor you can't contribute to health, you really shouldn't be buying a car. So if you are buying a car, we should have a registration system in which, okay, you are paying so amount if you are not already contributing to health. Somehow, and even for those who we know don't have income, we can verify they don't. Why don't we find a way to get them skills or job? So get like maybe even government or private companies get some kind of a way they can set up small or large business where they can employ people and automatically withhold taxes that will be paid towards health. So we need to have people working so that they can add value to the system, and that's where we can have money for health. Thank you.
Okay, I think who among the panelists will answer the first question about we have beautiful hospitals built, yet people don't go there? So.
Well, maybe I'll take that on again with a little story. I told my governor, I said to him when I came on board, if I were here, I would not have recommended that you build these hospitals that we're still building. There are 3 hospitals that are now being built in each of the senatorial zone. And if you know my state pretty well, not only do we get quote maybe the least amount of money, even though as a state I think we can do better by collecting taxes, but also we are one of the states in the country, I believe, that has challenges with human resource for health. If here we are with general hospitals that don't have as many doctors as they should have, don't have enough nurses as they should, why go building, big hospitals when you don't even have the resources, that are needed, both human and otherwise. But having said so, we're making sure that having invested that, in these 3 hospitals, that they then become what they should become. Otherwise, we'll have wasted a lot of money. So I think that we need to come up from structures to functions. I mean, you go to certain places, it's not the big structure, but what goes on there. What is provided in those structures. Experiences in other developed world, it's not, you pass a hospital, you won't know it's a hospital. But when you go in there, you know it's a hospital providing first-class services. So it's not edifices, it is what goes on there. And I want to agree with what the Honorable Minister presented, that the primary health care must be the starting point. Even if you are paying, you are contributing from mandatory contribution, and you need service, and you decide that you're going to go to secondary health care, to access, there should be a penalty for that. You pay, if you have that money, you want to, circumvent starting at your primary health care level. So whatever, your status, you should start at the primary health care level. And I think that is necessary in terms of strengthening, the facilities at that level to be able to achieve what we want to achieve in terms of providing quality services. So I want to agree with you because it's an experience all over the states. People think that when they build castles, they will be remembered for that. It's not easy, to quantify, input into healthcare, because it's not something you readily measure. But in terms of, the years that you live when you keep somebody alive, there are scientific ways, and that's why the Honorable Minister mentioned